Hey guys, this is FixerMed. Welcome back to my ECG Skills Builder Workshop, where I will be covering all of the fundamental knowledge and skills you will need to read and interpret an ECG in a quick and effective manner. This will be part 15 of my multi-part video series of doing so. Today, we will be taking a deep dive into ECG abnormalities in regards to P waves, T waves, and QRS complexes. Without any further delay, let's go ahead and get started on today's content. Let's start off with atrial hypertrophy. The tall P wave, greater than or equal to 3 blocks, signifies atrial enlargement, may be widened in bifid. Biphasic P wave in V1 indicates right atrial enlargement. P mitral in lead 2, biphasic P wave with a negative deflection indicating left atrial abnormality. Commonly seen in mitral valve disease, particularly mitral stenosis. Let's next look at ventricular hypertrophy. Left ventricular hypertrophy. Large S wave in V1 and a large R wave in V5. Criteria: if the sum of the height of S in V1 and R in V5 in millimeters is greater than 35 millimeters, then left ventricular hypertrophy is probable. Often seen in individuals with pre-existing hypertension, chest pain, and inappropriate thrombolytic therapy due to misdiagnosis of ST segment changes in V1. Right ventricular hypertrophy, large R wave in V1, and less so in V2 and V3. Often secondary to pulmonary stenosis. Other features: right atrial hypertrophy, right axis deviation, and T wave inversion in leads V1 to V3. Let's next look at principles in relation to ischemia, infarct, and injury on the ECG. QRS complex is not the most affected part of the EKG waveform in ventricular ischemia. ST segment is most often affected. Transmural ischemia, ST segment elevation, unstable angina, acute myocardial ischemia. Severity: as ischemia becomes more extensive, ST segment elevation becomes more pronounced. Localization: the lead with ST elevation helps locate the ischemic infarcted area. Inferior leads indicate inferior myocardial involvement, while lateral leads indicate lateral wall involvement. Let's continue on to look at more principles in relation to ischemia, infarct, and injury on the ECG. Differentiating pathological ST elevation from non-pathologic J-point elevation, elevation of the terminal portion of the QRS, dips down towards the baseline, then rises back up to the ST segment. The J-point elevation is also known as the Osborn wave. Pathological ST elevation, terminal portion of the QRS goes directly into the T wave. Let's continue on to look at even more principles in relation to ischemia, infarct, and injury on the ECG. Progression to infarct. After ischemia progresses and tissue scars, the ECG shows an inverted T wave. Q wave development, a pronounced Q wave, not normally present, and loss of all or part of the R wave may be present. Subendocardial ischemia, ST segment depression, stable angina. ST depression is not localizable to a specific lead, but is seen in leads with the tallest R waves, leads 2-3 AVF and V4 to V6. Typically self-resolves, but like elevation, depression increases as myocardial ischemia increases. Let's now look at Prinzmetal's angina. Main sign of it is ST segment elevation, where the predominant area of ischemia is epicardial. Cause: thought to be related to vascular spasm. Angiography: shows coronaries without significant atheroma. Other features: many other morphological abnormalities have been described. Let's now look at hyperkalemia. Peaked T waves are the most prominent feature. Other features include stretching of the entire waveform, serial changes 5.5 to 6.5 milliequivalent per liter, tall peak T waves 6.5 to 7.5 milliequivalent per liter, loss of P waves 7.0 to 8.0 milliequivalent per liter, widening of QRS complexes 8.0 to 10 milliequivalent per liter, sine wave, ventricular arrhythmias. Let's now look at hypokalemia. In hypokalemia, the T waves flatten prominent U waves, may be falsely interpreted as QT prolongation. Other features: may have first or second degree AV block. Let's now look at digitalis toxicity. Effects: range from mild first degree AV block and junctional rhythms to fatal arrhythmias. ECG changes: swooping ST segment depression. Shortened QT intervals or first degree block, not distinguishable from primary first degree AV block. All right, guys, now that we have covered all of the content, let's go ahead and take a look at some questions to review the knowledge you have gained so far. A patient presents with muscle weakness and an abnormal ECG. The ECG shows tall peaked T waves and a widened QRS complex. Which of the following electrolyte imbalances is most likely responsible for these findings? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. The ECG findings of tall peaked T waves and a widened QRS complex are classic signs of hyperkalemia. This electrolyte imbalance affects the electrical conduction system of the heart, leading to these characteristic changes. As potassium levels rise, the resting membrane potential of cardiac cells becomes less negative, causing earlier repolarization and the peaked T waves. Further increases in potassium can slow conduction and widen the QRS complex, eventually leading to severe arrhythmias if left untreated. Therefore, the correct answer is B, hyperkalemia. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. Hypokalemia. This typically causes flattened T waves, prominent U waves, and ST depression, which are opposite to the findings in the question. C. Hypernatremia. While it can cause neurological symptoms, it does not typically produce specific ECG changes like those described. D. Hypocalcemia. This can prolong the QT interval but does not cause peak T waves or QRS widening. E. Hypercalcemia. This may shorten the QT interval but does not cause the specific ECG changes seen in hyperkalemia. All right, now that we have covered this question, let's move on to look at the next question. A patient arrives at the emergency department with severe chest pain. Their ECG shows ST segment elevation in leads 2, 3, and AVF. Where is the most likely location of the myocardial injury? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. ST segment elevation indicates acute myocardial injury, and the location of the elevation on the ECG corresponds to the area of the heart affected. Leads 2, 3, and AVF specifically look at the electrical activity of the inferior wall of the left ventricle. Therefore, ST elevation in these leads suggests that the patient is experiencing an acute myocardial infarction, heart attack, affecting the inferior wall. Therefore, the correct answer is C, inferior wall of the left ventricle. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A. Lateral wall of the left ventricle. This would be indicated by ST elevation in leads 1, AVL, V5, and V6. B. Anterior wall of the left ventricle. This would be indicated by ST elevation in leads V1, V4. D. Interventricular septum. This may show ST elevation in leads V1 and V2, but typically in conjunction with other leads depending on the extent of involvement. E. Right ventricle. This is less common and may show ST elevation in right-sided leads like V3R and V4R, but typically in conjunction with inferior wall involvement. All right, now that we have covered this question, let's move on to look at the next question. A patient with stable angina experiences chest pain during exertion. Which of the following ECG findings is most consistent with their condition? All right, I think I gave you guys enough time here. I'm going to move on to see what the correct answer is and what the reasoning behind it is. If you need more time, feel free to pause the video. Otherwise, moving on now. Stable angina is caused by a temporary reduction in blood flow to the heart muscle, leading to myocardial ischemia. This ischemia typically manifests on the ECG as ST segment depression, especially during episodes of chest pain. The depression reflects the imbalance between oxygen supply and demand in the heart muscle. Therefore, the correct answer is B, ST segment depression. All right, let's go ahead and see why the other answer choices are incorrect. The incorrect choices can be explained as follows. A, ST segment elevation. This is more indicative of acute myocardial injury, as seen in unstable angina or myocardial infarction. C, peaked T waves. These are typically associated with hyperkalemia, not ischemia. D, prolonged QT interval. This can be caused by various factors, including certain medications and electrolyte imbalances, but is not a typical finding in stable angina. E, prominent U waves. These are often seen in hypokalemia, not ischemia. All right, guys, that is all I have for this video today. If you like this type of content, be sure to leave a like and subscribe for more content like this in the future. Be sure to leave any questions, comments, or concerns down in the comment section below. This is FixerMed signing off. Be sure to have a great day, everyone, and good luck studying as always. Goodbye.